Hello people and welcome to another video from MedTube on how to differentiate ventricular tachycardia from SVT with aberrancy. Now if I give you this ECG, if you had to describe this ECG you would say it's a regular broad complex tachycardia without P waves. And the possible differentials for this ECG would be either ventricular tachycardia or SVT with aberrancy. So again, a wide complex tachycardia could be either ventricular tachycardia or SVT with aberrancy. And what aberrancy means, or aberrant conduction means, is that the supraventricular impulse is delayed or blocked at the level of the bundle branches or at the level of the distal Purkinje system, resulting in a wide abnormal QRS complex. And aberrancy could be due to any of the following. It could be due to a pre-existing bundle branch block, giving a wide QRS complex. It could be a rate-related aberration, which is a functional bundle branch block. And what happens is that the rapidly generated supraventricular impulses reach the conducting fibers and the Purkinje system before these conducting fibers fully recover from their previous impulse, i.e. they are still refractory. And such a delay in recovery of these fibers could be due to an underlying disease in the Purkinje system, or due to hyperkalemia, or due to certain antiarrhythmics. However, what is most important to understand is that these broad QRS complexes and the rate-related aberration will return to normal upon termination of the SVT. In other words, in a normal sinus rhythm, you will have normal QRS complexes and rate-related aberration. This is in contrast to bundle branch blocks, in which you will have wide or broad QRS complexes in normal sinus rhythm. And the third cause of aberration is called pre-excitation syndrome, involving an accessory pathway. And usually the pre-excitation syndrome is the Wolff-Parkinson-White syndrome, and the accessory pathway is called the bundle of Kent. And in pre-excitation syndrome, you would have a wide QRS complex tachycardia due to one of the two reasons. The first reason is that you have a re-entry circuit involving the accessory pathway, with the anti-grade conduction being through the accessory pathway, as seen in the antidromic AVRT, as explained in the previous video. And the second reason is that you have simply an SVT using the accessory pathway to reach the ventricles, rather than using the Purkinje system to reach the ventricles, and therefore this gives a wide QRS complex. And this kind of SVT could be atrial tachycardia, atrial flutter, or even atrial fibrillation. But of course, in atrial fibrillation, you would have an irregular rhythm. So these are the two main mechanisms in which you have a broad complex tachycardia and pre-excitation syndromes. Now, these are not all the causes of wide complex tachycardias, but you also have other few causes, such as ventricular paced rhythm, which is a pacemaker-induced tachycardia, in which you usually have a characteristic ECG finding, the pacing spike. Now, coming to the differentiation between ventricular tachycardia and SVT with aberrancy. And the first difference is that in ventricular tachycardia you have a very broad QRS complexes, which is more than 4 small squares, or 160 milliseconds. And this is in contrast to SVT with aberration, where you usually have a QRS complex duration of less than 4 small squares, but of course more than 3 small squares. Therefore, it's simply a wide QRS complex, but not very wide, as in ventricular tachycardia. And you can see here an example of ventricular tachycardia, and you can clearly see the very broad QRS complexes. Clearly, it's more than 4 small squares. And coming to the second difference, in ventricular tachycardia, you usually have an atrioventricular dissociation, in which the atria and the ventricles beat independently of each other. Now, please note that the term AV dissociation is different from the term complete AV block, in that AV dissociation has the ventricular rate usually higher than the atrial rate. This is in contrast to complete AV block, in which the atrial rate is higher than the ventricular rate. Whereas in SVT with aberrancy, we usually do not have AV dissociation. Now please note that most of these differences, which are 10 in total that we will be discussing here, are actually have low sensitivities. In other words, they will miss some of the cases and they are not always present on an ECG. Therefore, the electrocardiographic differentiation between ventricular tachycardia and SVT with aberrancy is not always possible. And here on this ECG strip, we can see an example of AV dissociation. We can see here that the P wave is superimposing on the T wave, giving a peaked appearance. And here we can see that the P wave is right after the T wave. And this indicates that the P waves or the atria are contracting independently of the ventricles. And coming to the third difference, which is the capture beats. And what it means is that the SA node succeeds to capture the ventricles in the middle of the AV dissociation. In other words, you will have a sinus beat in the middle of the ventricular tachycardia. In SVT with aberration, no capture beats. And here on this ECG strip, you can see a kind of normal sinus beat in the middle of the ventricular tachycardia. And this sinus beat, you can see it has a QRS complex of a normal duration. This is a capture beat, indicating a ventricular tachycardia rather than SVT with aberrancy. And coming to the fourth difference, diffusion beats. And what it means is that you have a sinus beat coinciding at the same time with the ventricular beat, and as the name suggests, this sinus beat is fusing on the ECG with the ventricular beat and hence giving a hybrid complex. In contrast to SVT with aberrancy, no fusion beats. And here in this ECG, you can see here kind of a hybrid complex. Doesn't look like anything normal. So this is a sinus beat superimposing on the ventricular beat, giving this hybrid complex. And after that, you can see two sinus beats with a normal QRS duration, and therefore these two are capture beats. And coming to the fifth difference, the Brugada sign. And this means that the distance from the onset of the QRS complex to the nadir, which is the lowest point, of the S wave of more than 100 milliseconds, which is more than 2.5 small squares. SVT with aberration, no Brugada sign. And you can see on this example here, from the onset of the QRS complex right here to the nadir, or the lowest point of the S wave here, is about 3 small squares, which is more than 2.5 small squares. Therefore, this is Brugada's sign. And coming to the sixth difference, the Josephson sign. And this means is that you have a notching near the nadir of the S wave, unlike SVT with aberrancy, which does not have Josephson's sign. And you can see here the notching right here near the nadir of the S wave. And now with the seventh difference is that you have an RSR prime complex with a taller left rabbit ear in ventricular tachycardia. And this is the most specific finding which is in favor of ventricular tachycardia. But again, this is not always the case. This is in contrast to SVT with aberrancy, in which you have a taller right rabbit ear. And again, this is not always the case. And you can see here on this ECG a taller left rabbit ear in ventricular tachycardia. And here in SVT with aberration, you can see a taller right rabbit ear. And since this is taken from V1, this is probably an aberration due to right bundle branch block. And now coming to the eighth difference between ventricular tachycardia and SVT with aberrancy, which is the following. You have complete positive or negative concordance throughout the chest leads, which are V1 to V6. In other words, you either have a positive concordance consisting of only R waves throughout V1 to V6 without Q or S waves, or you have a negative concordance with consisting of Q and or S waves throughout from V1 to V6 without R waves. And this is actually the first step in the Brugada algorithm to diagnose ventricular tachycardia. The bottom line is that you're not supposed to have RS complexes. An RS complex would have an R wave which is positive, an S wave which is negative. But again, this is not always the case, as some ventricular tachycardias do have RS complexes. This is in contrast to SVT with aberrancy, which does not have complete positive or negative concordance throughout the chest leads. Some are positive, some are negative. But again, this is not always. And here on this ECG, we can see a ventricular tachycardia with positive concordance throughout the chest leads. So you can only see precordial R waves. There are no Q or S waves, which are negative. So this is complete positive concordance from V1 to V6, indicating ventricular tachycardia. And here we can see a negative concordance throughout the chest leads from V1 to V6. You can see there are no R waves, so there's no positive concordance throughout the chest leads. This also indicates a ventricular tachycardia rather than SVT with aberrancy. And now coming to the ninth difference, which is the following. You do not have the typical right bundle branch block or the left bundle branch block morphology in ventricular tachycardia, and that's due to certain patterns that we will be seeing shortly on the ECG. In contrast to SVT with aberration, which is actually due to a bundle branch block, so logically you will be seeing the typical right bundle branch block or the left bundle branch block morphology. So again, if you have a dominant R wave in V1, which is a right bundle branch block like morphology, we would be looking for the following patterns which are indicative of ventricular tachycardia rather than an SVT with aberration. And the patterns in V1 to V2 which are indicative of ventricular tachycardia are the following 3 points. The first is that you have a smooth monophasic R wave, or a taller left rabbit ear, or a QR complex, which is a small Q wave and a tall R wave. Whereas in V6, we will be looking for the following. Either a QS complex, therefore you have a negative concordance in V6, or you'll be looking for an RS ratio of less than 1, also implying you have a negative concordance in V6. And this is in contrast to the typical right bundle branch block, where you would have usually a dominant R wave in V6, therefore a positive concordance in V6. So here in V1, we can see the typical smooth monophasic R waves with only one peak and not an RSR prime pattern. Or we can have a taller left rabbit ear indicating ventricular tachycardia, again in V1, and you can see here that the left rabbit ear is taller than the right rabbit ear. And the third one is the QR pattern, a Q wave followed by an R wave, and this is also indicative of ventricular tachycardia rather than an SVT with aberrancy. Here we have the typical right bundle branch block morphology, and you can see the RSR prime pattern in V1 with a taller right rabbit ear, and this is indicative of a right bundle branch block. And here in V6 we can see the QS complexes with the absence of R waves, therefore a negative concordance in V6 suggestive of ventricular tachycardia. The waves you can see here are actually the T waves, not the R waves. Or we can have the R to S ratio of less than 1. So you have R waves, but they're simply shorter than the S waves. Therefore, it's still a negative concordance in V6, suggestive of ventricular tachycardia rather than a right bundle branch block. Now, if you have a dominant S wave in V1 and hence a left bundle branch block-like morphology, we'll be looking for the following patterns on the ECG suggestive of ventricular tachycardia. So on V1 to V2, we'll be looking for an initial R wave of more than 30 to 40 milliseconds, so approximately more than one small square. This is in contrast to the typical left bundle branch block, where you would be having very small R waves. The second thing is the Josephson sign, as we have described before, which is the notching or the slurring of the S wave, and this is suggestive of ventricular tachycardia. And the third point is if you have an RS interval of more than 60 to 70 milliseconds, which is the duration from the beginning of the R wave till the nadir of the S wave. And now with the patterns indicative of VT in V6, and the first is that you have a QS complex, and therefore a negative concurrence in V6, just like in the right bundle branch block like morphology. And the second is that you have a QR pattern or a QR complex, same thing. And actually in this pattern you would be having a positive concurrence in V6, but you have a Q wave, a small Q wave, followed by a tall R wave. And this is in contrast to the typical left bundle branch block, where you would be having an absent Q wave in V6. And you can see here, this is in V1 and V2. In letter A, you can see the wide QRS complex. In the letter B, you can see the Josephson sign, the slurring or the notching of the S wave. And in the letter C, you can see that the QS interval is more than 60 to 70 milliseconds, indicating ventricular tachycardia. And here we can see in V6 the QS complexes, so negative concurrence in V6 without R waves. And this is just like the QS complexes seen in V6 in the right bundle branch block like morphology. And here we can see the QR complexes. So although in V6 it's a positive concurrence, but you have Q waves, and this is in favor of ventricular tachycardia. Here we can see the SVT with the left bundle branch block, and typically you can see the absent Q waves and the positive concurrence in V6. And lastly, with the last differentiation point, is that you have an extreme axis deviation in ventricular tachycardia, also known as northwest axis. This is in contrast to SVT with aberrancy, no extreme axis deviation. And here on this ECG, we can see that lead 1 is negative and lead AVF is negative, and we can also see that AVR is positive, all of which are indicating that this is an extreme axis deviation, also known as northwest axis, and this is indicative of ventricular tachycardia. And now coming to the last point in this video, which is the clinical presentation of the patient. Who is the patient and what does the patient present with? And this also helps us in differentiation between ventricular tachycardia and SVT with aberrancy. And this is particularly important because, as I have mentioned before, the ECG findings alone are not very reliable in differentiation, and that's because of the low sensitivities of most of these findings. So the clinical presentation, the first thing is that if the age is more than 35 years old, it's more likely to be a VT. And the second thing is that if the patient has a structural heart disease, an ischemic heart disease, a previous MI, a CHF, a cardiomyopathy, or a family history of a sudden cardiac death, all of these are more related to a ventricular tachycardia. And actually, if the patient is presenting with a broad complex tachycardia in the setting of an acute myocardial infarction, this broad complex tachycardia is almost always due to a ventricular tachycardia. This is in contrast to SVT with aberrancy, where the patient is usually young, less than 35 years old, and if the patient is a child, it's almost always an SVT with aberration. And the second thing is that if you have a previous ECG showing a bundle branch block pattern, especially if the QRS morphology is identical to the QRS morphology in the broad complex tachycardia, or if you have a previous ECG showing a Wolff-Parkinson-White syndrome. And the third and the last point, which is not mentioned here due to space limit, is if you have a previous SVT which was successfully terminated by vagal maneuvers or adenosine, this increases the likelihood that the current broad complex tachycardia is due to SVT with aberrancy rather than ventricular tachycardia. So this is the end of this video. Thank you guys for watching this long. And in conclusion, I'd like to say that these are not all the criteria, but there are also a few other criteria mentioned in some algorithms as the Vericchio algorithm and the Brugada algorithm. Thank you again for watching, and hopefully I'll see you with the next video on irregular tachycardias.